Hey everyone, welcome to this explainer. Listen, if you're gearing up for the ACSM exam, you already know that Chapter 2 of GETP 12, the Pre-Participation Evaluation, is an absolute beast. It is literally one of the highest yield chapters you're going to face. We're talking exact numbers, hidden traps, and precise criteria. So today, we're going to lock all of that down together so you can absolutely crush this section. Let's get right into it.
Okay, let's dive into this. Here is your ultimate cognitive roadmap for this intense study session. We're looking at the 4 evaluation components, the screening algorithm inputs, avoiding those big exam traps, the exact CVD risk factor criteria, blood pressure and lipids, and finally, the AACVPR risk stratification. Let's hit it.
All right, Section 1, the 4 evaluation components. This is the foundational framework of the whole pre-participation process.
So, here are your 4 main pillars: consent, the algorithm, history, and CVD risk. Now here's the kicker. Informed consent must happen absolutely first. Before you gather any info, before you do a single test, this ethical and legal mandate has to be met. And it's not just handing them a piece of paper. It requires a verbal explanation where they have time to ask questions, all while being completely HIPAA compliant. Oh, and if you're running a facility, you need written emergency policies, and you've got to practice those drills at least twice a year. Seriously, do not let the exam trip you up on that timeline.
Moving on to Section 2, the ACSM screening algorithm inputs. Think of this as the core mechanics of the chapter. This is entirely about identifying exactly who needs medical clearance for aerobic exercise. So the crucial point is the number 3. I really want to aggressively anchor this in your memory. The entire clearance algorithm is built on only 3 inputs. Not 4, not 5, just 3.
And here they are. First, their current physical activity level. Second, any known cardiovascular, metabolic, or renal disease, or even just the signs and symptoms of those. And third, their desired exercise intensity. Now pay attention to how we defined a regular exerciser here, because it's a classic test question. It's the rule of 3s. They need to be doing planned, moderate intensity activity for at least 30 minutes 3 days a week for the past 3 months. Boom, 3s across the board.
Okay, Section 3, avoiding big exam traps. You really need to stay on high alert here, because the exam absolutely loves to pull some sneaky tricks on you.
Let's methodically unpack these. Trap number 1. In this 12th edition, CVD risk factor counting is not part of the clearance algorithm. Hear me on that. You still assess risk factors, obviously, but counting them doesn't automatically trigger medical clearance by itself anymore. Trap 2. Exercise testing is actually not required for clearance. The method of clearance is left entirely up to the physician's judgment. Trap 3. Hypertension is a risk factor, sure, but it is not categorized as a cardiac disease for screening purposes. And finally, Trap 4. Pulmonary disease, think COPD, does not auto-trigger a medical referral. Why? Because pulmonary disease alone doesn't raise the risk of a CV event during exercise, even though it often coexists with CVD. Watch out for those.
All right, take a deep breath. Section 4, CVD risk factor criteria. This is the heavy-hitting memorization phase of our study session. Every single cut point here matters, so let's lock them in.
Now, what's really interesting about this slide is how incredibly specific these demographic and lifestyle markers are. Let's get a rhythm going. For age, it's men 45 and up, women 55 and up. For family history of a cardiac event, we're looking at before age 55 in a male first-degree relative or before 65 in a female first-degree relative. Smoking? That covers current smokers, anyone who quit within the past 6 months, or people with secondhand exposure. And for inactivity, you're flagging anyone falling short of 500 to 1,000 MET minutes per week, or less than 75 to 115 minutes of moderate to vigorous activity. Got it?
Let's keep that momentum rolling right into the metabolic numbers. Obesity is the BMI of exactly 30 or higher, or a waist circumference over 102 centimeters for men and 88 for women. Blood pressure is a systolic of 130 or higher, a diastolic of 80 or higher, or just being on BP meds. For lipids, it's an LDL of 130 or higher, an HDL below 40 for men or below 50 for women, a non-HDL of 130 or higher, or a total cholesterol of 200 or higher. Meds count here too. For glucose, we're looking at a fasting plasma glucose of 100 or higher, a 2-hour oral glucose tolerance test of 140 or higher, or an HbA1c of 5.7% or higher. Oh, and here is a massive rule you cannot forget. If a risk factor is unknown or the client just doesn't disclose it,
it, you must count it as present. No exceptions.
But wait, here is my favorite part, the -1 rule. This is such a cool exception. If a client has an HDL, that high-density lipoprotein, of 60 milligrams per deciliter or higher, it is actively cardioprotective. That literally means you get to subtract one positive risk factor from their total count. 60 is the magic number there.
Okay, Section 5, blood pressure and lipids. We're diving into the nuanced classifications here because these are frequent targets for exam questions.
And this brilliantly illustrates why you absolutely cannot rely on outdated study habits. Under the old JNC criteria, hypertension started at 140/90. But look at the new ACC/AHA criteria. Stage 1 hypertension has actually moved down. It now starts at 130/80. That is a massive shift in how we assess risk, and you have to know it.
Let's walk through these columns together. Normal is less than 120 and less than 80. Elevated bumps the systolic up to 120 to 129, but the diastolic stays strictly less than 80. Then we hit stage 1 HTN, that's 130 to 139 systolic or 80 to 89 diastolic. Stage 2 is 140 or higher or 90 or higher. And listen, the golden rule to remember here is that a patient is always classified by whichever number is in the higher category, whether that's their systolic or their diastolic.
Moving on to Section 6, AACVPR risk stratification. Now we are shifting our focus away from apparently healthy populations and moving straight into clinical medical fitness settings for patients who have known cardiovascular disease.
Here, functional capacity and ejection fraction act as your main guiding compasses. Low-risk patients, they have a left ventricular ejection fraction, or LVEF, greater than 50% and a functional capacity of 7 mets or higher. Moderate risk, that LVEF drops to between 40 and 50%. High risk, that means the LVEF is heavily compromised at less than 40% and functional capacity tanks below 5 mets. Keep those 3 buckets crystal clear in your mind.
All right, it is crunch time. Let's do a final, quick self-quiz. I'm going to act as your hyper-caffeinated study buddy right now. I want you to mentally lock in your answers before I reveal them. Ready? Let's go.
First up, what are the 3 inputs of the ACSM screening algorithm? Got it? It's current physical activity, known disease or symptoms, and desired exercise intensity. Boom. Next one. What is the defining age criterion for a CVD risk factor? Lock it in. Men 45 and older, women 55 and older. All right, third question. Is an exercise test required for medical clearance? Careful, remember that massive trap we talked about? No, it is not required. It's left entirely to the physician's judgment.
Last one. What is the exact cut point for the negative risk factor? You got this. It is an HDL of 60 milligrams per deciliter or higher. Look at that. We made it. The key to conquering this evaluation chapter is locking down those 3 big areas: the algorithm inputs, the exact risk factor criteria, and those updated ACC-AHA blood pressure cut points. You've got the tools now. But here's a final thought for you. As science evolves, we literally watch the hypertension thresholds lower so we could catch risks earlier. What metric do you think the ACSM might tighten up next in future editions to keep our population safe? Think about it. Trust your prep, trust the process, and you are absolutely ready to conquer your exam. I'll see you in the next explainer.